Hello. So I'm Keith Jones, the Surgical Director of the ISCP. I'd like to welcome you to a specialty-specific recorded session for neurosurgery related to ARC preparation. So I'm delighted to be joined by Simon Thomson, the Chair of the Neurosurgery SAC. And we're hopefully going to answer some questions or ask and then answer some questions which will be helpful to both trainees and trainers related to the first round of the ARC pre-process for this new curriculum as of started in the summer of 21. So Simon, thank you very much for making the time for us to do this. So my starting question is what do you see as the meaning of the critical progression points related to the end of phases 1, 2 and 3 for neurosurgery?
The new curriculum, or the current curriculum as we should call it now, is divided into 3 phases, which are similar to the old phases of the curriculum, but not quite the same. And it's important to point out the differences between the new and the old curriculum. The first phase is what we would previously have considered to be the early phase, or is ST1 and ST2. The ST3 year has previously been in the early phase, but it is absolutely not in the early phase or in phase 1 of the new curriculum. So it's ST1 and ST2, and the idea is that this takes someone from a raw neurosurgery recruit to the point at which they are able to conduct themselves as the on-call neurosurgical registrar, certainly with some support, because that's what's required for an ST3. So at the completion of the phase 1 part of training is the phase 1 critical progression point. And for the phase 1 critical progression point, you have to, at an ARCP, prove that you've got adequate skills in the general professional competencies, in the SIPs, in the critical conditions, and in the index cases. It is also required that you have passed the FRCS exam for the phase 1 critical progression point. Now, the critical conditions, there are 10 critical conditions. They're not complicated or nuanced. They are very core, basic parts of neurosurgery, and they include things like impaired consciousness and seizures, trauma, hydrocephalus, tumor presentations, spontaneous hemorrhage in the brain, and infections, spinal trauma, spinal oncology, degenerative spinal conditions, particularly Cordray-Quiner syndrome, and pediatric emergency neurosurgery. Now, clearly, at the end of phase 1, a trainee is going to know an awful lot more about impaired consciousness and seizures than they are about emergency pediatric neurosurgery. So there are defined levels of competence that are expected for the phase 1 critical progression point. So, for example, the impaired consciousness and seizures, you are expected to be at level 4. That's the level of a consultant. However, for emergency pediatric neurosurgery, you're only expected to be at level 1, which means you have had some experience of it. These are assessed with case-based discussions, and we expect 3 case-based discussions for each critical condition by the time of your phase 1 critical progression point, which can be at any point during phase 1, any of the previous 2 years you can have done that. Do you want me to go on and talk about index procedures as well, Keith?
Well, no, I was just going to clarify. So at the end of phase 1, there would be 30 assessments at the required level for those critical overall for the critical conditions.
Yes, that's correct. Of course, people may have done more than that, but if they've not reached the required level, they're not going to count, as it were.
And the level is related to CBD or KEX outcome. So it's that marking system.
Yes, that's correct.
Excellent, thank you. And for the phase 1 the critical progression points for within the SIPs, that they're very clearly shown on page 48 and also page 12 of the curriculum, and then, so as expected, significantly lower
for the end of phase 1, and that shows the level of development and learning that occurs in phase 2.
That's correct. So the SIPs, the new curriculum is all about high-level assessments of trainees and sort of general competence across broad areas of practice. And the SIPs are all about your ability as a neurosurgery doctor in a sort of high-level way. So we look at things like outpatient clinic activity, unselected emergency take, that's the on-call, the ongoing care of inpatients on the ward, operating lists, and multidisciplinary team meetings. And we don't expect a high level of competence, for example, in multidisciplinary team meetings at the end of phase 1. It's some experience, but not a high level. On the other hand, you should be able to go around and see patients on the ward in a very limited supervision type role and look after the vast majority of the problems on the ward by the end of your phase 1 training, because that's what you're going to need to do on the day 1 of your phase 2 training. So you have to get that competence before you go through to the next phase.
And so segueing hopefully nicely through to talking about the index procedures, as example, the level expected for the completion of phase 1 as a capability and practice for the management of the operating list is level 1. But we recognise that managing the operating list is a far bigger component than just the technical skills, but there are very clear technical skill levels related to the index procedures for the completion of phase 1.
Yes, there are. So now the index procedures are different in phase 1 and phase 2 and 3. They're different in terms of exactly what we're assessing. So there are 6 index procedures for phase 1, none of which feature in phase 2 or phase 3 as index procedures. The 6 procedures are lumbar punctural and lumbar drain insertion, insertion of an intracranial pressure monitor, burr-hole evacuation of a chronic subdural hematoma, insertion of an external ventricular drain, craniotomy, any craniotomy, and lumbar decompression, which is really designed to mean posterior lumbar spine approach and closure. And this is a high level of surgical expertise by the end of phase 1 training. And again, it is designed in a way to ensure that the day 1 phase 2 trainee is capable of doing the registrar on-call training, but it will mean that ST1 and ST2 trainees will need to spend more time in theatre than they perhaps historically have done in the past, and they need to reach certain levels of competence. So I would expect you to be able to do a lumbar puncture or put a lumbar drain in to the level of a consultant. Really, you should be able to put it in and deal with the any sort of simple complications that occur. I'm not talking about removal of a spinal hematoma, but certainly dealing with a leak around the drain or something along those sorts of lines. I have been asked by one trainee whether they can all be lumbar punctures or whether they all have to be lumbar drains, and the answer is a mixture would be nice. And what you have to do is you have to impress the ARCP panel on your ST1 critical progression ARCP that you are capable of doing both of these procedures. Again, it is three of each, but now we assess these with procedure-based assessments, not with case-based discussions. And there are procedure-based assessment forms either that already exist or that are being produced for the assessment of each and every one of these. And we'll expect 3 at the right level by the end of phase 1.
As part of the critical progression points, therefore, at the end of phase 1, as we talked about the capabilities in practice, the critical conditions, and now the index procedures, the curriculum is very clear of, and we have a bit reiterated tonight, the numbers required for the critical conditions and the index procedures related to supporting evidence, and there would be an expectation that a trainee would have achieved that evidence, otherwise they would not be completing that phase of training.
Well, yeah, I think that's right, Keith. The curriculum is established in a way that you go through phase 1 training to get to a level of a day 1 registrar, and if you haven't reached the standard, you have to remain within phase 1.
And so I would see that perhaps a recognition for the ST1s watching that this is one of the changes of the newer curriculum, that your older peers might not reflect you, that you would be looking to spend more time in the operating theatre than they may have done previously when they were doing the same job 3 or 4 years ago.
I think that's right.
So that's, to me, very clear, so thank you. If we moving on to talk about the phase 2 and in relation to their critical progression points, that again clearly shown within the curriculum, and they're set at skill levels for, but the assumption is, from my looking at it, that for certainly the critical conditions, the expectation would be to complete phase 2, you would be at the level of a day 1 consultant with relation to knowledge and skills for all 10.
Yes, so that's right. So it's worth just bearing in mind that phase 2 critical progression occurs, it's designed to be indicative. It's not exact, but it's designed to be about a year before your certification date. It tends to correspond roughly with when you take the exam. We'll come back to talk about the exam shortly, I think. But the point is that you pass the exam. The exam is set at the knowledge level of the day 1 consultant, and you will go through your phase 2 critical progression point at about the same time. Some people it will be before, a few people it will be a bit after, but it's about the same time. So the knowledge levels, which is really to a great degree what the critical conditions measure, are set at the end of phase 2 at the level of the day 1 consultant, all across the board. They're the same critical conditions as in phase 1 training, but the level of knowledge that is required is that much higher than at the end of the phase 1 phase 1 progression point. So, for example, if you look at the impaired consciousness and seizures, which is level 4 for phase 3 and level 4 for phase 2, but is also level 4 for phase 1, you will actually already tick that off. You'll already have your 3 case-based discussions at the level of ST1 or ST2 for your phase 1 critical progression point, and in fact you will not need to do anything further to tick that one off when you get to your phase 2 critical progression point. But conversely, and perhaps sort of opposite, the emergency pediatrics neurosurgery, by the time of your phase 2 critical progression point, you're expected to have reached level 4, and that's a big step up from where you were at the end of phase 1. So there are some additional case-based discussions. Again, it will be 3 case-based discussions for each of those categories, so 3 times 10. But you have had 5 years in phase 2 training, the average trainee. Plus, as I've said, you may have got some experience that you can count from phase 1 as well.
Excellent. And at the end of that phase, across the board for the CIPs, the expectation is that the minimum standard, the indicative standard to finish the phase would be indirect supervision in all aspects of the neurosurgery specific parts.
Yes. You're not at a consultant level. You're not competent to be a consultant, but you're getting very close to it.
Excellent. And for the index procedures at the end of phase 2, there are clear indicative PBA levels to achieve. Can I ask the numbers that you undertake at the end of phase 2 to get to the levels required, therefore, to the 3s, mostly level 3, but some level 2s, do they continue to count as you move forward to the final phase, or is the indicative number then again at the higher level?
Okay, so the neurosurgery curriculum is, we know that the final year of training in neurosurgery is really important. It's where you learn your really microsurgical skills. And it's about the hand. It takes the trainee from someone that knows an awful lot about neurosurgery to someone that can do the whole lot of neurosurgery. And that final year is really, really important. What that means is that the index cases for completion of phase 2 training and the index cases for completion of phase 3 training, although they're the same category, the standards required for phase 3 are higher. So at the end of phase 2, you are not expected to be performing all surgical procedures, technical skills, to the level of a day 1 consultant. Unlike the critical conditions where you are expected to have the knowledge of the day 1 consultant. The distinction here between knowledge of the day 1 consultant and the technical skills of the day 1 consultant is really important. At the end of phase 2, you should have the knowledge of a day 1 consultant, but not necessarily the technical skills of a day 1 consultant. That's what the final year of training gives you. It gives you the technical skills to bring you up to the complete rounded picture of a day 1 consultant, which of course is what phase 3 critical progression, otherwise known as certification, is.
So would it be reasonable to say that by the end of phase 2, a trainee and therefore trainees assessing them ought to have a clear understanding about what their learning curve is like and what their best learning environment is like, such that the trainee that learns quicker and obtains competence quicker may therefore get the competency levels at a lower level of indicative procedures than the slower but nevertheless high achieving trainee.
Okay, so going back many years, there was a big focus on numbers of cases done, and we have moved away from that now, and we really talk very much about competence. However, it is the case that you do need experience to get competence, and you need a breadth of experience across a whole wide range of different presentations of the same pathology as well as different pathologies, of course. So we have retained a few indicative, and it's important to emphasize the word indicative, logbook numbers, but those are only for certification. There are no logbook numbers required for any other phase of training. That doesn't mean, but what you do need to do for the phase 2 critical progression point is produce 3 PBAs for each of the index procedures. And of course, the PBAs are about competence, they're not about numbers. And you can do that at any point during your phase 2, or indeed if you're very good through your phase 1 training, but I don't think that's realistic that many people will do it in phase 1 training.
Excellent, that's very clear. I wonder if we can go back to, as you mentioned earlier, to exam entry and the requirements for that. So for neurosurgery, the entry point 2 years prior to expected CCT?
Yes, I believe it's the same common for all surgical specialties now, but the requirements for entering the exam are that you have a outcome 1 at your most recent ARCP, that you have the support of your training program, which effectively means your training program director, and that you are within 2 years of your expected certification date. Those criteria have been put together so that people will continue to take the exam during their ST7 or ST8 year, because unless the timetable for the exam changes, that means within neurosurgery, the first exam you can usually take is in the February or March of your ST7 year, which gives you 3 sittings of the exam before certification, even well, I mean, unless you're really exceptional, but for the standard trainee going through, you've got a year and a half of sitting exams. It's every 6 months. It has been designed to reflect the same sort of entry level as the exam has always had historically. Most people who pass the exam on the first sitting will therefore, when they get to the ST2 critical progression point, which not always, but is an indicative point, tends to be at the end of what we would currently call the ST7 year, will have passed the exam. But not quite everybody. Some people will be retaking the exam, and it's important that, unlike the phase 1 critical progression point, for the phase 2 critical progression point, you don't have to have passed the exam. Most people will have done, but it's not absolutely required. It's a sort of, it would be nice, you know, it's sort of expected, but not absolutely required to go through the phase 2 critical progression point. You do have to pass the exam for certification to go through the phase 3 critical progression point.
Excellent. Now that's very clear, and that segues us nicely to the certification requirements. Because they're the same as it would have been at the end of phase 2, and there wouldn't be any additional evidence required.
Yes, so of course, if you've, well, you will have done, if you will have all the evidence required to get through the critical condition criteria for the phase 2 critical progression point, although the critical conditions do still appear in a table as a requirement for phase 3, it's an identical table to the one for phase 2, and therefore you shouldn't have to do any additional case-based discussions during your final year of training.
The supervision levels within the SIPs would have moved on to level 4 or 5 relation to supervision levels for all of the SIPs. So the bigger change just relates then to the index procedures. They move on the whole to level 4 PBA level, but there are some recognising the potential for subspecialty progression and interest post certification.
Yes, that's correct. So, so for basically the broad spectrum of general neurosurgery, they're level 4. You need to be capable of doing the operations, treating the patients, dealing with the complications. That's what we would all expect the consultants to be able to do. There are some areas of neurosurgery that are now so subspecialized post certification that actually you've only really got to be able to deal with the emergency presentation of conditions within those sort of special interest type areas. And that applies in particular to pediatric neurosurgery. So we do expect you to be able to deal with most aspects of emergency presentation of pediatric neurosurgery. You should be able, for example, to do a shunt procedure in a knee in a baby. You should be able to deal with a child who presents with intracranial infection, but you do not need to be able to deal with complex craniofacial reconstructions, which is so super specialized now. It's not even done in every neurosurgical center in the country. So for pediatric neurosurgery, it is only a level 2 requirement, or 3 if you happen to have done it as a special interest during your final year. For complex spinal fusions, that's the insertion of lots of complicated metal work. Again, you would certainly be expected to be able to deal with spinal trauma and deal with it overnight. And there is a requirement to be able to put in pedicle screws and fuse spinal injuries. But there is not necessarily a requirement to do the highly complex stuff, unless it's going to be the sort of thing that you want to do post certification, and the same applies to pituitary surgery. We absolutely support the view, the GMC's view, that we're producing a generic neurosurgeon. You come out, you at certification, you are a neurosurgeon capable of doing any special interest thereafter. It is also the case that that final year of training, you need to develop the microsurgical skills, and you can develop those microsurgical skills within a special interest area. So, for example, you could do you may do 6 months of spinal surgery, or you might do 6 months with an acoustic surgeon, and you will learn the microsurgical skills that are very transferable between those two specialties. So as your microsurgical skills develop within acoustic surgery, for example, you could then go on to get a spinal job and use those microsurgical skills within a spinal job. So it's designed so that you can develop a little bit of an interest prior to certification. But I must emphasize that the aim of the curriculum is to produce a generic neurosurgeon who is able to go on and treat all neurosurgical conditions, particularly all those that present in an acute way.
And so, can I ask, for a trainee, in relation to paediatric neurosurgery, that placement, or the majority of their placements, may occur within phase 2, and therefore is it relevant, or presumably it's relevant, that they achieve that they can certainly achieve the certification levels during those placements, so they'd have already got them, because they wouldn't necessarily have to repeat them again in phase 3, because they can be looking at a more focused training in the third phase.
Once you've reached the level of a day 1 consultant, you don't need to prove that you've reached it again later on in training. You only have to prove it once, that you've got to the level of the day 1 consultant. But for most people, that will be in their final year of training.
Excellent, brilliant. I think that's really clear, and I think we've covered all aspects that hopefully makes it for trainees to understand what it is that they need to be looking to achieve and work towards for their summer ARCPs, and also hope that any members of the panel that watch this have a clearer understanding about what the expectations are. So Simon, thank you very much indeed for your time.
Pleasure, Keith. No problem. Thank you.